Hello, my name is Professor Joyce Harper and I'm Professor of Human Genetics and Embryology at University College London in the Institute for Women's Health, and I'm also co-director of the Embryology and PGD Academy, and we've been offering training courses in IVF and PGD for almost 20 years. And today I'd like to talk to you about genetic screening of embryos. Have we found the Holy Grail? I'm sure you all know about pre-implantation genetic diagnosis, and PGD is a reproductive option for couples that are at risk of transmitting a specific genetic or chromosomal abnormality to their children. So probably most of them will go through prenatal diagnosis, but for some we can offer pre-implantation genetic diagnosis. And in this procedure, the couples go through routine IVF procedures, we generate the embryos in the lab, and then we remove some of the cells from the embryo. We can either take the first and the second polar body at the zygote stage, we can take 1 or 2 cells from the cleavage stage embryo, or we can take up to about 5 cells from the trovectoderm at the blastocyst stage, about day 5 of development. Once we've removed these cells, we can perform genetic analysis, and over the years the genetic testing has really advanced significantly. And now if we're going to look at chromosomes, we can use array comparative genomic hybridization, where we get an idea about all of the chromosomes in the embryo. And more recently we have started using next generation sequencing or massive parallel sequencing, where again we can use this for aneuploidy, just looking at the number of chromosomes, but this is going to be developed in the near future to also look at the molecular level and to look at single gene defects. So that's the outline of PGD. We would do the diagnosis, and any embryos not at risk of the particular genetic or chromosomal abnormality from that couple will be considered for transfer. But what about embryo selection? Well, we can use this technology to look at pre-implantation genetic screening, and this procedure, PGS, has been used mainly for infertile patients who are going through IVF anyway, but they may want to add on a stage where we can look at the chromosomes or screen the chromosomes from the embryos they make to look at their chromosomal status. So for these techniques, most people now are using array comparative genomic hybridization or the sequencing methods so that they can look at the chromosomes present in these embryos, and from this information decide which embryos will be transferred to the patient. Now, really to see if this embryo selection method is viable, what we need is results from randomised controlled trials, which will show us that using this procedure gives us a better delivery rate than if we didn't use PGS. There are some early studies using array CGH, and there are some studies now being done on sequencing, but at the moment we're still gathering information to really be sure that analysing the chromosomes from embryos is going to improve delivery rates. But what we do know is that looking at these chromosomes in embryos, we can tell which embryos have a chromosome abnormality, such as Down syndrome or other chromosome abnormalities, so these embryos would not be considered for transfer. One complication in PGD and PGS is that human embryos are very mosaic at the cleavage stage and even to a lesser extent at the blastocyst stage. This creates a slight problem because the cells we remove from the embryo might not be representative of the rest of the embryo. And using sequencing, especially at the blastocyst stage, we're detecting much lower levels of mosaicism, and it's a discussion at the moment whether these embryos are suitable for transfer. But certainly some clinics now, if there's low level mosaicism over a chromosome that's not viable, for example not chromosome 21, these embryos may be considered for transfer. And in the near future, genetic testing is really being developed. I think it's important for everybody working in reproductive medicine to understand about genetics. As well as PGD and the advances in PGD and PGS, we've got extended carrier screening, which is very much being rolled out in IVF units now, where we can test a couple, test their blood to check whether they're carrying a low level risk of carrying the same genetic abnormality, which would lead to an abnormality in their offspring. And early data seems to imply that about 2% of couples, when we test them together, are both unfortunately carrying an abnormality in the same gene. So this extended carrier screening will give us useful genetic information, and the couples can then make an informed choice about their reproductive options. But any of us could get a genetic test. I myself have done the 23andMe test and found out a lot of information about my own genetics. And certainly in the near future, this will be expanding out to the population, as it gives us important medical information that could affect our treatment for various disorders. So I encourage everybody to really read up on genetics and learn about it, and thank you very much.